All right, I think we're going to get started. Welcome to the Vascular Access in Neonates and Infants session today. We're going to talk about techniques you know and those you want to know. I'm Julie Montaguto. I'm the Vice Chair of the Critical Care Committee, and I'll be moderating the session with Arul and Natalie.
I'm Arul Thuramorthy from Michigan, also a pediatric surgeon, critical care.
And I'm Natalie Drucker. I'm also a pediatric surgeon at UT Houston and also doing critical care.
All right, so this is not really supposed to be a lecture. We're going to use some slides for visual assistance only, just to talk about some of the techniques today. We are planning on doing a case-based discussion, so feel free at any time to interject and share your experiences or your questions about the techniques we're going to describe. We're going to try to cover a few different scenarios, and the timing is flexible. But everything that we're planning to discuss is going to be available on a Google Drive for your reference, even if we don't have time to discuss all of it today. So you'll be able to access it any time with a QR code. I wonder if that's on the next slide. There we go. So that QR code there will be the one that you may want to use. Give you a minute for that. All right. So we'll get started. The QR code's still there, but we have no financial disclosures. And we're going to start with our first case. So you're called at 3 a.m. to the NICU to see a 500-gram baby who was just transferred in from another hospital in septic shock. The baby's been there for about an hour or so, and several people, including the NICU, the PIC team, and the IR team have tried to get IV access and have been unsuccessful. So by show of hands, how many people in the audience here would be thinking about doing a cut down for access at this point? Okay. And how many are thinking ultrasound? And how many are hoping that the charge nurse will get an IV in before you get there? Yeah. We sent a survey out in advance of this session, and just to show you some of the results we have so far, only about 50% of the respondents have taught a fellow in the past 5 years how to do a cut down. So maybe 50% may not feel as comfortable doing a cut down in this situation. And that's confirmed by this next slide here, where only about 40% of the respondents said that they felt comfortable doing a cut-down line in a neonate. And then as far as the preferred cut-down site, the majority preferred to do a cut-down for the IJ. And then these are the data here for when the respondents graduated from their fellowship. All right, so Arul, I think now we'll talk about the options.
So we're going to talk, so it's not something that everybody's thinking about, particularly if you've graduated more recently. So, cut down options, the most popular, as Julie mentioned, is internal jugular. If you think about it, I think most people in this audience are comfortable doing IJ cut downs for ECMO. It's the same incision, it's the same access technique. You're going above the clavicle, you're cutting down, isolating the jugular. You'd still put ties on it. You don't have to ligate it. It's, some people like to ligate it approximately like we do for ECMO, but you can actually have control, make a small venotomy, I use hexoproline, but you can make a small purse string, pass your tunnel catheter down through it, tie it off, just that purse string just so it's tight, then close up, and it works out really well. So it's just it's a traditional cut down technique. Some people like to ligate in that situation. And so that's an option in emergencies as well if you can't get ultrasound access, right? So it's just not something that's on the first part of everybody's mind, but it's definitely an option. Facial vein is a very traditional first approach, particularly in shortcut children, but in very small or extremely low birth weight children, it's very difficult, if not impossible, and wouldn't be recommended in this patient or in a very small child. Saphenous, I'm going to defer to Natalie. She's going to talk about it next because that's probably the one people these days have done the least of. And then the one that actually doesn't occur to a lot of people is to do a umbilical vein, supraumbilical. Everybody who has done a neonatal laparotomy has ligated a umbilical vein. So you don't have to do a full laparotomy incision. It's a small supraumbilical incision. stay extraperitoneal, find the vein, same thing, control, and you can actually get into it as you would normally make a venotomy, and you pass a PICC catheter, it comes from 1.9 up to 5 French. You get an x-ray, see if you can get it up all the way up to the atria. If not, back it off and make it a high lying. And if all you have to do is get a couple centimeters in and tie it off, you now have a nice big IV to get access and get in. That's very quick. I think everybody who does this in their hands, it's just not first on our minds. So remember, this is a small child. We could probably do it within 2 weeks of birth, maybe up to a month. But in a micropreemie, this is a good option. It's going to be the biggest vein you can find, easily accessible, well tolerated, very safe, done at local at the bedside, right? So we're just trying to get in and get access.
So we're going to talk a little bit more in detail about the saphenous vein cut down. This cut down set, though, and kind of the setup applies to any of these options. So you go up to the NICU, you bring up all your supplies because they don't have this stuff up there. This is our cut down tray. It's just showing, you don't need that much. It all fits in a small box from the OR. You can set it up yourself and be ready to go. The top there, you can see some hemostats, some scissors, the needle drivers. There's obviously a scalpel, some Geralds, so it's fine-tipped forceps. Those are kind of fistula probes or dilators for the vein. That bottom middle thing is the tendon passer, which you can use to tunnel in a bigger kid. It's probably a little bit aggressive for a 500 grammer, but it can be helpful for tunneling in certain situations. That little retractor is called the ohm retractor, small self-retaining retractor with a screw that opens it, very stable retraction, especially if you're on your own. And then almost to the bottom right is the little, I don't know exactly what to call that, a little hook that helps open up the vessel. These really tiny vessels, it's hard to keep them open past the catheter, so that's a little hook that comes in our set, and then a small tip suction. This is like a little video of it up closer, which I think everyone kind of knows what those instruments are, but it's on the Google Drive for reference if you were trying to build a cut-down set for yourself. Doing the saphenous vein cut-down is it's simpler in a lot of ways than actually cutting down on a IJ or a femoral vein. It's very superficial, small incision, and can be used as kind of a long-term line. It can be tunneled pretty well. So the incision's about a 5 millimeter incision at the base of the inguinal lymphatic triangle. You can see it here. This is the left groin. The picture of the baby is the left groin. The picture on the right is the anatomy to visualize of the right groin. So the area that you're trying to target of the greater saphenous vein is where it's about to dive deep and dump into the femoral. You can see the little X in that picture on the right that demonstrates the area that you're trying to access. So make a little incision, go down through the skin. There's a little fascial plane beneath that. Once you pop in there and kind of spread in the direction of the saphenous vein, you'll enter this plane that's right on the vein called the plane of Leriche. And here it is kind of spreading. You can see there's not really room for a retractor. There's not really room for anything. They're holding open with the Geralds, spreading. And then there's a picture of just kind of how big the incision is. So that plane of Leriche is a key point of this, getting between that adventitial tissue and the wall of the vessel. That's when you know you have made it to the right spot. And then you're able to isolate that vein very easily. There should be no branches coming off of it. You should be able to get this little segment with no problem at that location. So there, the vein's isolated, the hemostats under it, it looks like a little Jake, and then a 5-0 or 6-0 silk around proximal and distal, and now you have control of that vessel. It's small, but it is open, and it goes straight into the iliofemoral system and up to the IVC. So then you prepare your tunnel. So this is an 18-gauge angiocath. You can pass it with the needle and with the angiocath through a tunnel, really minimal tissue trauma, tunnel it through, pull the needle out, and then pass the catheter through. And then now you kind of situated with this PICC line here. This is a silicone 1.9 French 2 lumen, double lumen PICC line. We have at the end, we have a list of all the lines and everything that you guys can reference in the future, but this is what it looks like when it's tunneled. So tunnel it out of the diaper area. It doesn't have to be far. These are small babies, but it's good to get it out of the diaper. and then cut it on a sharp bevel. Here's the picture, around the level of the xiphoid. So you can use fluoro if you have it. If not, just guess the level of the xiphoid and the path that it would take to get there. And then you can use one of these micro beaver blades or even just an 11 blade, tie the caudad side of the suture, and then make about a 50% venotomy in the saphenous vein, and then pass it bevel side down so that you get that little tip of the bevel in, and then advance it, and it dilates up the hole and gets it into the right spot. When you pass it in, it should pass freely. It should go all the way in. It's going to go into the IVC. If it doesn't, or it stops somewhere, it's probably in a lumbar. You should pull back pretty much all the way to the venotomy and try again, kind of twist it in a different angle. And those are kind of just tips and tricks to get it in there. And then once it's all the way in, they're passing it there. And then here it's all, suture up the skin and then secure the line in place, and you've got a really stable access for a baby like this in pretty quick progression. This can be done under local at the bedside without any imaging until the end. And so let's throw it back to Julie here. Yeah.
So raise your hand at this point if you would think about using an ultrasound to put in a line in a 500-gram baby.
Anybody?
Okay. Our next slide, I think we have some of the survey results. Which of the following vessels would you use ultrasound to access? And clearly the IJ would be the preferred location. And then when you're deciding between doing a cut down or a percutaneous access, what are the factors that make you decide to do a cut down? And so, this was a free text people were writing in their responses, but in general, it seemed that size was the major criteria that people used to make the decision between doing ultrasound guided or cut down. So, Arul, I think you have some techniques to tell us about ultrasound guided access.
So, so for me personally, I will still try to do ultrasound access in kids this size. It's difficult, and so we're going to kind of walk our way through it. But it's doable, especially with practice. So one is to target the IJ subclavian junction. That's going to be with ultrasound, the standard linear probes that most of us have access to. We can see it. It'll be a relatively large confluence, and that's your biggest target. And these are small children, so we're talking a pretty small step. It's like a centimeter, and you're not having to dig very far. So use a micropuncture needle. So that's going to be, I like the 4 French 7 centimeter, it's a 21 gauge, with the 018 wire. That weigh 1. It still seems pretty big in that patient size, but that's a very easy one to get in. You can try to use some of the smaller, even finer ones, like for the PICs, but I find this to be the easiest. I don't like a syringe on the micropuncture needle. I just hold it just on the hub right there. Any extra weight on the end throws it off. So that's why I use a 7 centimeter, because the length of the needle, you don't want it to be hitting your hand on the probe. And so the micropuncture access needles and some of the others that come in a 4 and a 7 centimeter, the 4 is you're going to get in your own way. You can try holding the L-shaped probes the other way around, but in general, you want to have options for being able to rotate your hands. So the 7 centimeter, even though it seems long, and it can seem longer than the child, keeps your hands enough out of the way that you can really get access. So recommend the hockey stick probe, like a L14, but that's a standard size. It's a linear 14, it's a hockey stick shape. A lot of people try to use a standard linear probe, and I'll show you guys some of these choices, but this gives you the most options. It's a high hertz probe, average is 12 hertz, and it'll give you really good visualization for superficial structures. Some of them are rated up to 6 centimeters, but our purpose is we want 1 to 2 centimeters. And in small kids, we're talking half a centimeter. My personal smallest is about 450 grams, 1 pound. I've heard rumors that people can do it smaller, but that's about my cutoff. And the child I'm going to show you guys is just a touch over 500 grams. So positioning, it's standard, small roll, bump. I think I rolled up a Curlex or something to make this here. And this is just one that we did about 2 months ago. Expose the right neck. You can see a little bit of gel left there on the neck. And then there's another type of probe. This is also a linear probe. This is a very small, fine, it's very short. It's a centimeter in length. Actually, it's less than a centimeter in length. It's another option for very, very small kids. While I have this picture here, all the pictures that we're going to show you are really from the standard linear probe. I actually prefer this one for small children's art lines, just because it's very fine and spacious, but you just have to try what works. So these are the two that I'll have on the machine if I'm trying to do a small child. I'll show you guys the actual brands of this. This one can be hard to find. Very few people will have access to it, but you can pretty much do everything with the hockey stick probe. And that's my go-to for almost 90% of what I'm doing. So for your standard probes, and I want to get too much into this, the standard diagnostic range for probes is 2 megahertz to 15 megahertz. And the shorter the wavelength, the better the detail and resolution. So if you're doing like abdominal imaging, you may not only have a larger probe, it'll be at a lower hertz so that it can get deeper penetration. So higher hertz, megahertz, shorter wavelength, more absorption, but also less resolution. But almost always, and for all the things that any of us would be doing for vascular structures, we want a high resolution probe because we're really not going to be less than more than 2 centimeters in for almost anything. And for the purpose of this talk, it's shallow. Maybe you're doing a teenage art line in the PICU. You can use a larger linear probe for that. Let's see here. I can get into the crystal effect. So we talk about what's going on for sound waves, right? So the piezoelectric effect, it's really electrical energy being converted to mechanical or kinetic, and the crystal either sends out a sound wave, or when the sound wave comes back, it's getting reconverted to an electrical signal that gets interpreted. And the reason this matters is when you're looking at probes, if you want to get a different probe for your machines, thinner crystals, not just length, have different effects on wavelength. So a thinner crystal has a shorter wavelength, which is going to get you to this higher resolution. Most of us are using linear probes. That's a sequential probe. When you're looking at the machine, you can see the track on the ultrasound screen, and that's called a sequential probe. Each one of these crystals is being fired. They're individually isolated. It's going to be 128 to 512 individual crystals in each one of the linear probes, and most of the ones that we're all using will have about 128. Curvilinear probes, which are made for abdominal imaging, are still sequential. They're just set into a curve to give you a wider field of view. And then a phased is what we're all familiar with for like echocardiography, where it gets you between the ribs or look under the xiphoid. It's actually a signal coming out of a pinpoint, or called sector shape, and directing that signal allows you to see a region, a pie shape, without having to move the probe. Not optimal for access with the needle, but hence you can use it. And this will be also on the slides, but these are the different hertzes. And so we're looking at between 10 to 15 for our purposes, vascular imaging purposes. So this is just a selection of probes. So that far left is an L14, and that is a really wide probe. It says Phi-W on it. That's a very wide and long probe, which is not that useful for our purposes. That bottom one is P4, is a phased array. That's your classic echocardiac probe. The L20 is a 2 centimeter net length. It's actually 1.8 functional, but that is one that a lot of people have on their sonocytes or other ultrasound machines. So it's not bad, and that's probably what a lot of us learned on, but it's really not as good as the one at the far right. So that's, and it doesn't matter who the manufacturer is, that's an L14. L just stands for linear, and the 14 is just the length of the crystal, 1.4 centimeters. That bottom right one there is an L30. It's not L30, but that's the little really small one. So that upper right is the one that I'd recommend you get if you want to do this or use for everything. For all different equipment, we have different lines you can use, the PIC lines, and then on the right to the micropuncture kits, as I mentioned, 4 7 centimeters, and I strongly recommend the 21 gauge 7 centimeter with an 0.8 wire over trying to use the PIC line set. And then you can have different lines. The 2.5 French Cook arterial lines, a very nice line if you need one even to use as a venous line. And I often use this double lumen 5 French, and they also make a single lumen 4 venous lines, which is, well, I'll show you guys in a moment. Actually, I believe, yeah. So this is some of the, for this initial patient I show you guys, is the ultrasound images. You can see the carotid in the upper left there, and then with the measurement, that's a carotid, and the upper left is the IJ. This is the other side. This is further imaging. This child is incredibly, gets very edematous, so hence you can see distortion in the tissues, but you can still isolate the vessels. So this is further imaging for the IJ there, and one of these there it is. So you can see effectively you can see the sternocleidomastoid, you can see skin up top, see the IJ and then the carotid below it. I can tell, I took a lot of these images because I want to have no doubts of where I am and what I'm getting the needle into. That's actually probably the best picture there. Okay, so access. I absolutely believe that you need to pile a lot of gel on the space you're going into. And it's important not just for visualization, but any pressure on these children will collapse the vessel. So you have to have your hand resting somewhere. Elbow on the table. These kids are too small to rest your hand on their chin, but you need to have your hand floating in the air, whatever it takes to stabilize it, whether you need to put a towel down or anything else, but you can't put any weight on it. So when I'm taking fellows through this, I won't let the probe touch the skin. And if I see any distortion, we stop and we kind of reset. So you can see where the needle is, and you can see that's actually a pad of gel, and that's what those little white specks are showing us. And you need to see your needle passing through that gel before it enters the skin so that you know you're not compressing. And then we can see where the SCM is. In this case, we're going through the SCM. I try to usually go lateral. It's easier to pass a tunneled catheter, but then we're getting set up. Now here, we're coming through the skin. We're starting to distort, and so first coming in under the SCM. Now here, we're under the SCM and coming right into the IJ, and this is with everything in line, okay? Now you can see the tip of the needle in the IJ, but you don't actually know that you're fully in. There's tenting of the vein. You may see flash. Another thing I teach is never look at your needle, all right? Never look for flash, because you don't know if you're just through the endothelium and you're really well seated, because at this point you might think, oh, I have some flow, I can pass the wire. Your needle will get pushed out. Like, this is probably an experience we've all had, where you're trying to pass the wire because you think you're in, but really you're hoping you're in. And you can get the needle better seated before you pass the wire. And that's really important in these kids, because you often only get one shot before you have too much hematoma or spasm. This is going further needle into the vein. And that's, yeah. There we go. That's, you can see the tip of the needle in there. And this is, I'm trying to advance it. So right here in the bottom left, you can see the needle into the vein again. I know this is all a little bit distorted. There we go. That's probably the best example. This is what I was looking for right there. We're just above the IJ subclavian junction. You can see the tip of the needle. You can see how it's actually through and almost to the other side. At this point, I'm going to advance the needle deeper in, and actually almost down to the level of the RA in these kids before I put the wire through, because that's the only way I know I'll get enough purchase. The other thing I always want is, when you're looking at your needle bevel, the bevel has to be pointed towards the feet, because otherwise when your wire goes in, it's going to get direct in the direction of the bevel. So it'll either, if it's pointed upwards to the head, the wire goes up to the back wall. So you really always have to be pointed to the feet. All right, so this is a slightly larger patient, but easier to show. You can turn your probe either way. This one is showing it off the toe for the purposes, there we go, of the, actually, I'll let you guys watch this now. Okay, so that's this subclavian IJ junction. You can see how it's a very large confluence. See the needle coming in, coming under the SCM, and then you can actually, you raise the hub of it so you're angled in, tenting of the endothelium, now you're in. So that's the first part of this. And then right here, just kind of got teed up on this one. But now this is rolling your hand, and you can see movement of the needle. So take the hub, and you're actually trying to take it towards the head. And that's going to swing the tip of the needle towards the feet, right? And that's how you can get it advanced. And then you roll your hand gently to watch the needle tip at all times to make sure you don't lacerate the vein. And that's how you get depth. And then you can get the wire down. And only if I do all those things have I been successful in these really small children. Any other shortcut of trying to just get it in, I just push, the needle pushes right out. And so. And that's the completed line. And there we have it. This was actually the single lumen 3 French, because it's such a small child. But this line worked great for an extended period, and got what we needed. Well, I say extended period, through the treatment course.
Okay, so now we're going to shift gears to a different kind of case. And we're talking about a 4-day-old term infant who is in profound hemorrhagic shock after being mauled by a dog. In the emergency room, no one is able to get IV access, and the veins are totally collapsed. So, Natalie, what kind of options might we have in this situation?
So this is a time where we have to kind of think outside of our normal surgeon box. So how many people in this room have put in an umbilical line in the past 5 years? And how many people have put in an IO? That's good, that's a lot. It's something that I feel like we as surgeons sometimes forget about because we do central lines. You know, we stick the big veins and we pass the catheters, and that's what we're comfortable with and used to. And so it's good to remember, you know, in this situation, you can do any of the things that we've talked about already today. You can do ultrasound guided, you could do a cut down. There's various options, but the things that we don't remember as surgeons is something that we wanted to highlight today. So umbilical catheterization can be done. We talked about cutting down on the umbilical vein, but you can even just still place an umbilical line through the umbilical cord up to around 10 days of life. This kid, that it was a real case, the patient was at home, so home with her dried up umbilical cord kind of just still hanging on. And it can be re-moistened and the end can be cut off and you can place an umbilical line. This doesn't have to be a real umbilical line. So I mentioned there 2.5 to 5 French polyurethane catheter. Those are the umbilical venous lines that we have in our hospital. Those are the sizes. But you can put anything in. You can put in a central line, a double lumen central line. You can put an angiocath. You can put probably up to 5 or 7 French in an umbilical vein. So it's important to remember. Here's kind of a review of how to do it for people that haven't done it in a while. Get a umbilical tape around the base of the umbilical cord. You have to moisten it with a lap usually if it's been dry, and then use a scalpel to cut the tip off and forceps to hold open the vein and pass the catheter. If you get it in about 1 to 2 centimeters beyond the point at which you get blood back, that's a secure line. You don't need this to last forever. It just needs to get the patient resuscitated enough to get out of the trauma bay. And sometimes, you know, people can freeze in this situation, and we, as pediatric surgeons, are often we have to remember all the different options and not just the things that we're most comfortable with. You tie down the umbilical tape to prevent back bleeding from the arteries. If that doesn't work, you can always ligate those individually. And then the other thing to mention is intraosseous access. So any baby can have an intraosseous line. You can go as small as preemies if necessary in case of emergency. The Easy IO, this is that drill system that we're all really familiar with. So their smallest one is a 1.5 centimeter or 15 millimeter needle. That's the pink one. So you can remember pink for pediatric, blue bigger, and yellow is big bird. That's kind of how we remember the sizes. So the smallest one is around for the 3 kilo babies, and then the greater than 3 kilo, you're looking at the blue, and then the yellow's for adults, so any bigger kid or an adult. Then there's also the manual ones. So the left side here shows the Cook needle and the Illinois needle, which are the two that are typically used for manuals. They are both 14, one's an 18 gauge and the other one comes in 14 to 18. These are used for bone marrow aspiration as well, or they can be used as a IO infusion. So they're placed by a gentle kind of drilling motion, kind of like putting in a laparoscopic trocar. And there's actually videos on the Google Drive. I didn't want to get too into IO because everyone kind of knows the principles, but we have the videos on the Google Drive for your review. In terms of choosing the length, the most important thing is that you want to make sure it's long enough to get through the cortex and into the marrow. Once you put the needle in and it touches the bone, you want to make sure you have at least 5 millimeters still showing on top of the skin. If not, you're going to have it not all the way into the bone, and that's when you get things like compartment syndrome, infusing the soft tissues, and the big complications that happen. I've seen probably 3 in the last 2 years, compartment syndrome from poorly placed IOs, so this is not something that's foolproof, even though kind of anybody can do it, but you got to make sure you do it right. So if you put it in and it's too shallow, then just get it the next size up. And make sure that you can really flush easily before actually infusing anything. The 2 sites that are the most common are proximal tibia. Proximal tibia is definitely the most common, I would say. You can also do proximal humerus in babies, contraindications or any problem with the bone, so fracture, infection, hardware. Here's just a quick review of the proximal tibia site, about 1 centimeter below the patella, 1 centimeter medial to the tibial tuberosity. All this stuff is on the Google Drive as well to remember, but it's flat aspect of the tibia, and you just place it right there and make sure it's seated really well. Same thing for the humeral head, which we're going to go past here in the interest of time. So those are just things I think it's really important to remember. In a crisis situation, you have these other options that we don't think about and we're not used to, but we have the capabilities of doing those things as well.
So the final case is a baby that's born at 32 weeks and was prenatally diagnosed with a lower urinary tract obstruction and resultant hydronephrosis and renal failure. He's 1.2 kilograms and requires urgent dialysis, with the ultimate goal of peritoneal dialysis until kidney transplant. So, Natalie, what are the options for hemodialysis in a baby this size?
So this is something we're seeing more and more. These younger and smaller kids that are being born that maybe wouldn't have survived previously with things like the RAFT trial, kids with oligohydramnios and renal failure are being born and needing dialysis to be supported until they can get on peritoneal dialysis. It used to be, or it is still, kind of a challenging clinical situation, but we've had a good little series of these, so we wanted to share this as information for anybody who's trying to do this as well. This is the line that we typically use in babies this small. It's just a standard cuffed, tunneled central line. It's a polyurethane central line with a cuff. It comes in 6 French and 5 French. We prefer to put the 6 French in. Almost always you can fit a 6 French in. Every once in a while the baby's too small or the vein's too small and you have to do a 5 French. The 6 French flows better for dialysis. They're power injectable. Don't be tricked because the power line also comes in a non-power injectable form and it's like very sneakily written on the packaging, so it's very important to get the one that can flow at 5 milliliters per second. That's the only thing you can do dialysis through. This is what comes in the kit. So it comes with it's Seldinger technique with a peel away sheath. You can do it that way. You can do it through a cut down. Any of the access techniques we've described, you can do it. We actually have oftentimes put it in at the time of ECMO decannulation. So you're ready to come off ECMO, but you still need help with fluid management in some of these patients, and we'll take the venous cannula out of the neck and replace it with one of these lines with the purse string and just kind of tunnel it, and then they're ready for dialysis as soon as they come off ECMO.
Just, we wrote a paper on this a couple years back. When we look at these lines that are being placed at the time of ECMO, really none of them come out for infection, and 80% of them will last through the entire treatment period, and the only complication is clotting. So that's an opportunity that should not be wasted, right? So that's what we were talking about, like patients who are on ECMO need dialysis or other line access. Let's not waste that vein that's been tied off.
Yeah, you've already sacrificed the vein. You might as well get the most out of it that you can. We have we cut the tip in this kind of special way, which we thought was helpful to share. So these scissors are not ideal for this, so usually it's a little bit smoother with some sharper scissors. But we kind of cut the sides off both ends of the line, or both sides of the end of the line, so that you end up with holes at the tip and holes on the sides, so that there's not as much of a chance of the line kind of sucking up against the wall of the atrium and not flowing. Here's kind of a video of what it looks like at the end. So you have these little notches on either side of the line, and that helps with dialysis flow, we think. It works for us. And then here's a picture of kind of the line at the end. You do the exact same thing for any tunneled line where you measure it to the nipple or a third of the way from the xiphoid to the sternal notch, or with fluoro, depending on your situation at the time. And we aim for kind of upper right atrium SVC, atriocaval junction. If they're too deep, a lot of times they won't flow. They're pretty finicky, but if you kind of keep them in this range, they work really well. The polyurethane is very easily kinked, and so it's important to make that nice smooth tunnel and not kink it. And then often they need to be exchanged, unfortunately. These kids grow from 1 kilo to large while they're in the NICU, and each time as they grow, it needs to be exchanged pretty frequently. It's kind of a labor of love. This is the machine that we're using. I mention it because it doesn't seem universal. So this is the Aquadex machine, and it only needs a 35 milliliter extracorporeal volume. It's made for dialysis in babies, and it's much gentler, easier in terms of hemodynamic instability for small babies, and that's what we're using and having good success with these challenging kids. It does require some degree of anticoagulation. It can be modified if there's coagulopathy in the child to just anticoagulate the circuit versus anticoagulate the baby, but that you can't do it without anticoagulation. And that's what we have for that.
And what some of you might find is that you're going to be asked to place these tunneled dialysis lines in small kids. You know, if we think about it historically, the original, like the standard CRT circuit, the adult filter, kids could not tolerate it, right? So it was PD or nothing. But there is a filter that was used in Europe and Canada that has finally been approved in the US. So the last year or two, more and more institutions are either using the adult CRT machine or the Aqueduc. And so you're going to most likely be asked to place it. So it's good to know you have some options. And that's why we wanted to make sure we talked about this, because you'll be asked to place them in neonates. And then we compiled a list of all these different lines, all the things we talked about, different lines that if you don't have and you're interested in doing more of these things, whether it's the micropuncture needles, the IV lines that we're using, the PICC lines, and some of these others. So this is all available on the drive, all the way through the access kits. All right.
So we have a few minutes for questions now, and maybe while people are thinking about their questions, I'll ask Natalie if you have any problems with recirculation with the hemodialysis catheter.
We do, but it doesn't seem to matter too much. We're able to get enough filtration and pull off enough fluid to not have it be a problem. Most of the dialysis lines for babies are like that. They all have the reinfusion and the drainage at the tip, because the ones that are two-stage are too long for babies. Yeah. So it's not any worse than the bigger dialysis lines that we were trying to put in before.
Yeah, I'm pretty sure I think the smallest fixed length dialysis line is 19 centimeters, like cuffed, and I think it's 12 French. It's just much too big. So.
Yeah.
And the double lumen Hickmans are they can't handle the flow rate. I think they're rated for less than 2.5 mLs per minute.
Right.
So you have to do the power line, right? It's like the power ports when we're replacing them. It's got to be set up for a power injector.
Okay.
Hey there. Thank you so much. This is a great talk. I'm Laura Hollinger from MUSC at Charleston, and we too are about to start using Aqueducts and place these 6-French power lines. So I appreciate all the little tips and tricks for how to do that in this session. I wanted to provide one comment. I do still use cut down quite a bit in the small babies, because oftentimes they're so sick, they're on the oscillator, all these types of things. Your cut down tray is beautiful, but if your SPD is anything like ours, they lose those vein picks all the time. And I wanted to let everyone know that the NICU standard kit for like a UVC insertion has a plastic disposable vein pick in it. And I have found that to be clutch in so many situations when you're called and the kid is a pincushion and they can't get anything in. But like that little UVC kit, the disposable one that all the neonatologists have, has a nice vein pick. And I find that to be really helpful, especially when your trays are lost in SPD like ours are. I don't know, maybe it's just us, but.
It's a really good point. Like it's a plastic, I know exactly what you're trying to say, the yellow,
Yeah.
I'm pretty sure it's
Yeah.
yellow in those, and it also comes in the Broviac kits for the smaller ones. It's useful, yeah.
I'm Mindy Statter from the Children's Hospital at Montefiore. You really didn't go over the common facial vein cut down, and that has been my standard for the babies that are 500 to 550 grams, because there's no subcutaneous fat. The anatomy is so consistent. And I don't have data on this, but the one thing that bothers me about ligating the IJ or causing IJ obstruction in these infants is the concern of elevating cerebral venous pressure and contributing to intracranial bleeding. And these kids are so fragile, and it's just another consideration.
Sorry. So we talked about it, and one of the things is when it was informal polling discussion, a lot of people are not comfortable doing facial vein, even on older, larger children. And so trying to translate that experience to, even for our audience here, it's uncomfortable. It's one of those things that's becoming a lost art. It's actually something that we're talking about and actually investigating a little bit further. I have to be honest, I haven't done a facial vein cut down since, I guess, 7, 8 years. That's the last time I did one. And I'm trying to think through if I've never taken a fellow through it myself. And so that's why we didn't get into it, honestly, too much. We were trying to talk about the things we know. And there are, an option, but we know people have found it not as easy. I think, have a lot of experience doing it, so we didn't pursue it, but yes. And also as EJ cut downs as well as an option that we didn't
And a
discuss.
2.7 French Broviac generally slides right in.
No, thank you for mentioning it. It's an important thing. So if one's comfortable doing it, of course, as mentioned, EJ is also another option, external jugular, for cut downs, although the smaller kids, it can be difficult. And so that is definitely one of those things we need to, if you're not comfortable doing facial veins, I would actually say something that we need to really talk about, maybe put together some videos and actually, maybe that's next year's session.
I'm Shoaib from North Carolina. I have always successfully placed 2.7 French in a 24-weeker with 420 grams is my lowest. Thank you.
Any other questions?
I was gonna say, can anybody beat that?
Yeah.
Great session. Do you mind commenting on your fixation of the lines? Use of glue at exit sites, tape devices, stat locks, sutures. Comment on your fixation.
I would venture that I speak for all of us when I would say we suture them. We suture everything, tie it everywhere. That's what I would say. I mean, you can put dressings over it, but everything's got to be secure. Those dialysis lines specifically, when I was a fellow, I would put 7 sutures on them, 2 hubs, 7 different places, and then the line team, the rule was that if any one of those 7 was out, they had to call me right away to come fix it because they come out. The kid's skin is tears and moves and everything, so I just suture it as much as you physically can.
As we all know, gravity is different in the NICU, okay? And so, we were 100% on board, right? What it takes, sometimes actually I will try to put an extra suture around the catheter itself, like the bottom of the hub, and then I make sure it flushes. And actually for that video, I didn't talk about it, but actually Spencer helped me out with it, and he tied it down too tight and actually cut it out and redid it because we wanted it, but it was too tight, but it had to be there. And I didn't get into this, but the reason we ended up doing it is because the kid had a PICC line that had been lost and IR couldn't get back in. So that's how we got called to do it, because it stopped being accessible in other locations.
A comment, if for neonates, if you don't have the purpose-made intraosseous needles, an 18-gauge regular needle works and stands up quite firmly.
Great. Well, thank you, everyone.